Hello everyone. Today I will present about my endodontic case. And this is outline of presentation today. Let's start with patient history. Thai female patient age 26. Medical history. Patient deny any medical history, current medication, and no history of duct allergy. Patient complained that she has tooth discoloration on tooth 3-1. History of present illness. Last 2 years, patient has spontaneous dull pain that has duration for hours after she complete orthodontic treatment, and her orthodontist told her that she has to do RCT on this tooth. Subjective symptoms. Her symptom on charting visit is no pain or any symptoms. Examination result. First, extra-oral exam. Facial symmetry, no facial swelling, no lymphadenopathy. Next is intraoral examination. No gum swelling, but you can see gum pale is caused by applied rubber dam. Tooth 3-1 has tooth discoloration to yellowish gray, no caries or tooth fracture. Next is examination of tooth 3-1 and control tooth is tooth 4-2. Tooth 3-1 has negative 2 EPT compared with control tooth is positive 30. Tooth 3-1 has negative to cold and hot test, slightly dull pain when percussion, normal when palpation, and both teeth 3-1 and 4-2 has mobility first degree and normal pocket depth 1 to 3 mm. Next is radiographic finding. Tooth 3-1 has normal crown, normal pouch chamber, 1 root and 1 root canal. Periradicular has well-defined periapical lesion at apical 1/3 and normal alveolar bone level. So diagnosis of this tooth is pulse necrosis with symptomatic apical periodontitis. And treatment planning of the tooth is non-surgical root canal treatment. After that, internal bridging. Final restoration with resin composite filling. No preoperative treatment and not require anesthesia. Treatment provided. First visit charting OC. Second visit LT, MI, TMC. On second visit, patient has post-operative pain. So prescription ibuprofen 400 mg, 1 taps 3 times a day for 3 days. Third visit FRC. And next is review literature about pulse necrosis and orthodontic treatment. The prevalence of pulse necrosis after orthodontic treatment figure very widely, ranging from 1 to 14%. From tooth anatomy, the dental pulse has only bud source that penetrate from the apical foramen. Seldom vascular communication of pulse through the radial canal. So alteration of apical foramen may affect pulpal blood flow. Reduction of pulpal blood flow affect pulse oxygen intensity and harmful to dental pulse. But the study found no significant effect of orthodontic force on pulpal blood flow. Characteristic of orthodontic force is like continuous force, not certainly. The orthodontic force gradually disappear in the surrounding tissue by the property of plasticity of the connective tissue and the deflection capacity of the bone crest, providing no condition for the structural rupture of vessel and nerve to happen. And how tissue reaction to excessive orthodontic force. If force is greater than capillary blood pressure, cell death can occur and cell-free area form, called hyalinization. So tooth movement stop until elimination of hyalinization. Therefore, if heavy force are applied, the risk of pulp necrosis and calcific metamorphosis of the pulp is reduced to zero. There is insufficient scientific evidence to prove that orthodontic force irreversible alteration in pulp cellular response. However, history of dental trauma may be considered a risk factor for loss of pulp vitality during orthodontic treatment. Tooth discoloration during orthodontic treatment suggests that tooth discoloration does not always indicate pulp necrosis or devitalization. Theory observe the color change and differ irreversible treatments. And next is review literature about internal bleaching. Internal bleaching have many causes like dental trauma or developmental defect, but most common cause is intracorneal blood decomposition by hemolysis of erythrocyte in dental tubule, then release of iron and form ferric sulfide, that is black compound, responsible for the discoloration of tooth. And mechanism of tooth bleaching. Bleaching work by oxidation process, removing electron that allow large pigment organic molecule to be dissolved into smaller, less pigment. Next is the technique of internal bleaching. First, walking bleaching, first described by Spatzer. Technique consists of inserts the bleaching agents into the pulp chamber and then close the access cavity with temporary filling, and the dentist refreshing the bleaching agent on a weekly basis until a satisfactory color. Next technique is thermocatalytic, similar to walking bleaching. Use various heat form in order to accelerate the release of reactive oxygen species. Clearly, this technique is not advisable since heat can damage periodontal tissue and lead to root resorption. Next technique is inside-outside technique. Consists of simultaneous internal and external bleaching. In this technique, the access cavity remains open and patient is responsive for receive the bleaching agent daily. Therefore, the whitening effect rely on patient compliance. Risk of resorption seems to be associated with thermocatalytic technique and use of hydrogen peroxide greater than 30%. Next is discussion. Cause of pulp necrosis in this case cannot be ensured, and the clinical findings show no pathology and trauma history of this tooth. Lack of previous history of this tooth, such as record of dental history. treatment depending on clinical finding and diagnosis that negative pulse sensitivity test, apical radialization, tooth discoloration, so plan for root canal treatment and internal bleaching for patient complaint. Thank you for attention.